webinar series. It's about the update of the spine surgery, and our first topic is lumbar fusion surgery indications and techniques. We have very good talkers, very good friends here. And the first talk is minimally invasive surgery fusion techniques.
You have to give me. I cannot. So here we are. Question of how fusion could be done in a minimally invasive way. So basically, I would like to go through some just basics about why should we consider minimal invasive. There's three papers that have. This is one of them, the scientific basis of minimally invasive spine surgery for the multifidus muscle, and then two others. Those would be the basis to understand why should we consider muscle preservation accesses. So the idea is to get the post-op comfort, and for me, what's very important is to get much less iatrogenic instability by going through the muscle instead splitting the muscle. And also we know by the rehabilitation people that when you get a very nice muscle preservation, you have better coordination and better comfort. So you know that the multifidus muscle is the main muscle that is addressed when you go to the spine. The longissimus is much less important. And more we know we can feel the anatomy through the muscle, even using your fingers. Today we know also that we can access through tubes, through endoscopy, and we can place implants. So once you get those technology mastered, you can do fusions for 1, 2, or many levels. I will show you. So the technology today is accessing by tubes, placing a disc, distractors, and also placing pedicle screws, and more we have instrumentation that is dedicated to such surgery. Every industry is doing percutaneous screws, percutaneous rods, and also you have a wire-based screws or one-shot screws without any wire before. Insertion of the rods also is more and more sophisticated. Cages came recently also and could be inserted and expanded through tubes. The fusion is still the limitation. How to fuse a segment. Placing implants is easy, but fusion is done either by interbody devices or placing speculums or tubes on the facets and draining those facets. This is one of the expandable cage that is used by Michael Wong in Miami. Also, personally, I don't like to, when it comes to a long construct, I prefer to have a mini open on the sacroiliac joint and place my implant. That might be long, as you can see here. He does it percutaneously. This is the way I place my screws. It's a mini open access, and you can see I place 2 to 3 screws in the ilium and sacrum. So I prefer to do a hybrid access, open on the sacrum and then percutaneous above. Let's go through some examples. I wanna make sure that mastering minimal invasive decompression might save some fusion. Look at this patient who comes from abroad for surgery. He was complaining of claudication, and we can see that this deformity is is an indication for fusion, but I did not fuse this patient because I saved his stability by doing minimal invasive decompression. And this is, I'm following this patient for 2 years of decompression, and he had this decompression at 3 levels. So this is one level spondy here. I want to emphasize also is that I go posterior minimally invasively when patient had a low pelvic incidence, and I go anterior first and posterior second if the patient had a large pelvic incidence, because I restore better low doses, better segmental low doses when I go first anterior. Both are minimal invasive access. So again, the typical minimal invasive fusion is the TLIF. I show you how I do mine. This is a spondy at L45, and this is typically a minimal invasive cage, screws, and rod insertion percutaneous. Usually also when patient, as in this situation, had a low pelvic incidence, you can see here, this is a lesion spondy at L45. This is his pre-planning, and you see that the pelvic incidence is 54 degrees. And in this case, I will go typical TLIF. So placing the Jamshidi needles, then placing the wires, tap, and this is my 2 screws are placed on the opposite side, on the contralateral side of the symptom. And the ipsilateral side of the symptoms, I dilate and place my drill, get out the facets, and place a distractor in the disc space. And then I distract, and you can see that the rod on the contralateral side is sliding inside the screws. Once I get my distraction, I reduce the spondy, you can see on the opposite side, and take out my distractor. So this is before going in the disc, taking out the disc, shaving the disc, placing my cage, and this is the end of the story. So typically, I place my screws on the contralateral, do my disc work on the ipsilateral, distract, lock my distraction, place my cage, and bilateral screws. And this is the end of it. And when it comes to high pelvic incidence, I do OLIF first and percutaneous screws second. This is one of this is the case here. OLIF first, placing the screws second. I would like to share with you this, how important is anterior realignment. This patient had 2 levels, discopathy and back pain, and a very slight claudication. I've done his angio-CT here, and I went anterior with one axis, lateral ALIF at L5S1 and OLIF at L45. And look at the results. This is before. Look at his profile and the legs and the sacrum. This is after. So look at the sacrum before and after. So by just realigning anteriorly, we get the antiversion. We reduce the compensatory mechanism of retroversion of his pelvis. So this is before the anterior axis, and this is after. You can see that at the pelvic tilt, the retroversion went from retroversion to normal version. So deformity, fusing deformity and minimal invasive is also an option. You can see here a case where anterior realignment was done first and posterior fixation second. So you can see here the realigning this patient by combined approach. This is also another example here where I went for one step anterior cages and posterior fixation percutaneous. This is also typically a minimal invasive long segment fusion. And recently, I would like to share with you my last acquisition of this technology, robotics. And as you feel everywhere that the doctors, surgeons are planning, simulating surgery before executing the surgery. So we got the Maser robot here, and this is the planning the surgery first. I would like to share this one. So this patient had 2 levels OLIF and percutaneous screws robotically assisted. Screws are placed by robots. I mean, by assistance with the robots. And this is the post-op X-rays before and after. So as a conclusion, I think today minimal invasive access are almost the gold standard. It's getting more and more sophisticated. I would go often when it comes to I would say rigid deformity, and I need to destroy the spine to break the spine in order to realign. When it comes to minimal invasive, we have to consider, is it mono or multi-segmental fusion? Is it mobile? And make sure that we are respecting the rules of realignment, because this is no compromise. You have to respect the alignment, the proper alignment of each patient. Thank you.
Assaker, thank you so much. It was really, again, a great presentation. Because I think because of the connection, we couldn't get the algorithm. If you have low pelvic incidence, you're just doing posteriorly, am I right? And if you have high pelvic incidence, you're doing first from anterior, then you're doing the posterior, am I right? Yeah, Richard, welcome again.
Yeah, I just want to answer you. Yes, yes. If I have low pelvic incidence, TLIP will work. Did you hear me?
No, Richard.
Oh,
if you have
I think
low...
the network is not. If I have low pelvic incidence,
yes,
I go TLF.
Yeah.
If I have a large pelvic incidence tick in TLF, so I prefer to go anterior, restore as much as lordosis as I can, and then go percutaneous.
Yeah, it's clear now. So another thing that in some cases we have seen that you have used percutaneous iliac screwings. So how could you combine it with the main system, with the main road? Do we have some difficulties to connect the iliac screw?
Yes. So if you're doing short segments like in metastasis, it's not so difficult. But if you're doing a long segment, I do on the iliac and sacrum, I'll do it mini open.
Mm-hmm.
On my sacrum, I just open a small incision so I can control my rods, because as you said, it's not easy to bring the rod inside.
Yeah. Richard, thank you so much. It was really a great presentation as usual. Do we have any questions from the audiences? So Yaser Özgündüz is asking, Assaker, how upper root foraminotomies is possible for grade 2 listhesis through minimal invasive surgery?
How?
You can.
Onur, I didn't get the question.
Yeah, Richard, you can read it on the right side. On
On
the
the
dialog
chat's
panel.
okay.
Yeah.
I cannot see it.
Click on the chat.
Chat.
Low.
And did he write it in English?
Yeah.
I can't see chat, so
So
Tell me.
how upper root foraminectomies is possible for grade 2 listhesis through minimal invasive surgery? Can you
It's-
do?
yeah.
Uh,
You can unroof the foramen
Mhm.
by accessing a minimal invasive, but as we know, sometimes the foramen is so narrow that you need to restore height of the disc. So this is a strategy, but technically you can open a foramen even with grade 2 spondy. I do this also sometimes with I'm getting the right direction.
Thank you so much, Richard. So if we don't have